In this session, the corneal refractive surgery session, we'll be talking about very interesting subjects in the laser refractive surgery treatment. Of course, one of the issues which is very important in deciding if we are going to do laser refractive surgery for the patient or not is the corneal thickness, and sometimes this will alter the decision if you want to do LASIK, intralaSIK, or surface ablation with all its varieties, the PRK, the LASIK, or the EpiLASIK. So our first debate today in this area will be LASIK in thin cornea. Do you do LASIK in thin cornea or not? LASIK in thin cornea, yes or no? So whatever the measurements of the bachymetry, can you do LASIK or not? So can we put the question and ask the audience please to vote for this, the question. You have your voting pads with you. So we will vote before and after the debate. Can you do LASIK in thin cornea or you prefer not to do it? Any votes? Okay, so these are our votes. So 15 said no LASIK in thin cornea, where 3 only said we can do LASIK in thin cornea. So we'll see this with our speakers today, Dr. Fransico Carons. He will talk about there is no limit for LASIK even in thin cornea. Fransico.
Sure, I want to thank you for the topic. And as you see from this graph, my advocacy is very difficult. It's a very difficult topic to defend, but I will try to do my best and at least shift some of your votes. Can I have my slides on, please? This is the title as originally assigned to me, No Limits for Thin Cornea. Actually, I slightly changed the title, hoping that it's going to work. Oops, there, with a question mark, because I want you to read the title in a different way, like thin cornea is not a limit for doing LASIK. Not meaning that you can do whatever you want with the thin cornea. I just want to testify and prove that you may still do LASIK in thin cornea according to certain rules. Let's start talking about thin cornea. What is a thin cornea? We know that cornea has a normal range of thickness. The idea of defining a cornea as thin is purely surgical, or in another scenario, if you want to take a correct intraocular pressure measurement. But do we say that 510 is thin, 500 is thin, 490 microns is thin? This is still debated and still not, still controversial. Okay, let me talk about some rationale to avoid in LASIK in thin cornea. We know that corneal thickness is a risk factor for ectasia. This is what we don't want to have, and you see here a nice case. We also know that there is a relationship even strong in between the residual stromal bed thickness and ectasia, and all of us are looking for that magic number which may assess LASIK safety. Some points to discuss as regards a thin cornea as a risk factor to ectasia development. We have some literature that I want to review with you very briefly. Binder, back in 2005, divided two groups of patients, and he realized that in the range of corneas, in the group of cornea ranging 500 microns versus 546, there was a highly likelihood to have ectasia compared these two groups together. More recently, in two sequential papers, Randleman and his group showed that actually the thickness of the cornea before surgery can be considered as a risk factor, and I hope to have my slides back because I'm not remembering exactly what to say. There you are, perfect. And you see that he used to say to give like a score to assess the risk for doing LASIK in cornea relatively thin. But at the end of his two studies, the thickness of the cornea was assessed as a weak risk factor. For instance, topography asymmetry, residual stromal bed thickness, and young age were much stronger factors than the preoperative corneal thickness as itself. And more recently, Tamer, in a paper which was published about 1 year ago in the Journal of Cataract and Refractive Surgery, assessed that there were no more risk factors in doing LASIK on a thinner cornea than thicker cornea as regards ectasia or other results. So what are we doing? What are we dealing with today? I think that the most important point to talk about is the residual stromal bed thickness. You know that this value, this figure was originally set by Jose Barraquer, and the magic number was supposed to be 250 microns. Nowadays, we are more looking to higher numbers because of safety issues. But you see here again from the work from Randleman and colleagues how the residual stromal bed thickness is assessed in terms of risk factors. So the thinner you go, obviously, the more risk is to developing ectasia. So residual stromal bed thickness ranging 280 to 300 microns is considered a low risk factor. Residual thicknesses of more than 300 microns did not show any tendency to develop ectasia. But is that the way that we want to measure residual stromal bed thickness only as a pure numerical value in terms of microns? Wouldn't it be more worth it measuring it as a ratio compared to the ablated tissue? Let me give you an example. Here is a case of a patient with a residual stromal bed thickness, 300 microns, with a flap of 120 microns. If the original thickness was 600 microns, what we have as a residual is 1.6 times the original thickness. Let's make the same figure as regards the second case example with an original thickness of 450 microns, where the residual stromal bed thickness in this case is 5 times. So which of the two corneas are going to be weaker or stronger after the LASIK procedure? There is also another way for looking at the same issue. Do we want to consider residual stromal bed thickness as a percentage of the original corneal thickness? And again, I'm going to give you a couple of examples. Let's set the original stromal bed thickness at 300 microns and an original total corneal thickness of 600. In this case, we have 50% of the residual tissue. What about the same case with a thinner cornea where the original thickness was 480? So in this case, we have 63% of the original strength of the residual thickness. Which of the two corneas is going to be stronger at the end of the LASIK procedure? So, to go back to the point that I was highlighting, do we have a magic number for thickness? Well, we know the answer. The answer is no. Unfortunately, we don't. We cannot say 490 is a safe number to go above or below. We cannot say 300 microns is a safe residual bed thickness to start with. We cannot say any ratio versus volume or percentage of residual stromal bed thickness. Unfortunately, we can have different numbers, parameters, but there is nothing that can really assess the final number. And most of this, what about the other risk factors we are taking in considerations, like age, topography, family history? So unfortunately, we have nothing as given for granted. Just to better clarify what I'm talking, again, I want to give you a couple of case examples as to prove you that in some cases, doing LASIK in thin cornea can be even less dangerous than what we usually do. This is a case of -2 diopters spheric correction that we know it ablates about 30 microns, depending on the platform, with a 485 residual microns corneal thickness as a starting point. So in this case, the risk score is 1. But if the flap is thin and leaves 360 microns of stromal bed, if the ablation leaves 345 microns residual stromal bed thickness with no actually risk score, well, I think that this is a procedure with a very, very low risk of corneal ectasia. Let's get the same numbers for the second example, and unfortunately my slides are gone again. Okay, same -2 correction, same roughly 30 microns. We start from 550 microns corneal thickness. Obviously, we don't risk anything theoretically, but what we have an asymmetric bow tie in this case, it may be also a young patient. So in this case, the procedure, at least as regards the published science, looks more risky in terms of corneal ectasia than the previous case, with the case with the thin cornea. Let's be even more provocative, a case with a significant high myopia. Again, same story, about 130 microns in terms of ablated tissue, which gives a risk score of 1. If we start from a thick cornea and we make a very nice flap, leaving a lot of tissue, and we leave a lot of residual bed thickness, well, guess what? In this case, we have the same risk factor as the previous case with a very thin cornea to start with. So the procedure like this, where we do almost every time without even concerning if it is risky, gives you the same risk factor as a thin cornea. There are even mentioned at this point that if we don't consider other parameters like a thinner cornea, like maybe some age factors inducing a higher likelihood of ectasia, a case like this is significantly at a higher risk than the procedure I started with in terms of thin cornea. And the final question that I want to ask you is if you really believe that thin cornea means weak cornea, because I don't think so. I think that this is not this is just an assumption. The thin cornea is not per se a weak cornea. We know nowadays how to measure a weak cornea. We have technology, we have systems to assess it. And I want to stress on the fact that certainly corneal thickness is a risk factor, as well as other abnormalities in regards to the cornea, as well as a low residual stromal bed thickness, as well as younger age, as well as family history. So there are several risk factors. And all risk factors should be taken into account when planning for LASIK. A thin cornea just limits us in the amount of tissue that we can ablate or in the flap thickness that we can attempt. That's the only limitation that a thin cornea produces. So, to conclude, to me, a thin cornea does not mean a weak cornea, at least per se. A thin cornea is simply a cornea that it is more likely to be turned weak if we don't respect all other risk factors. A thin cornea is just a normal cornea, but thin. As the last comment, a thin cornea is just a normal cornea, but think more about it. That's it. Thank you.
Very good presentation, Francisco. This I'm going to be thinking about. So, on the other hand, Dr. Antonio Marinho will talk about no LASIK in thin cornea. Antonio.
My slides, please. I thought when I saw the program that I will have to contradict my friend Francesco, but really I think we are almost in synchrony about this. Of course, when we speak about LASIK in thin cornea, we must understand that there are limits of LASIK. LASIK cannot be used to correct every hemetropia, and the thickness of the cornea is just one of these limits. Of course, we know that LASIK and surface ablation are the most widely practiced and popular forms of refractive surgery. However, even if perfectly performed, but the indication is not correct, they can lead to very catastrophic situations. Remember, or of course all of us know that in myopia we ablate the central cornea, changing the shape and the contours of the cornea. And the normal cornea, as it was said before, has very different thickness that even is different from region to region of the world. Here in the Middle East, for example, there is a lot of thin corneas, but it's not only the thickness that matters, also the curvature of the cornea that is important to limit the LASIK, and of course also the normal cornea is in a spheric shape with no edges. So, when cutting a LASIK flap, we should not forget that we cut through the strong cornea. So, as it was said before, it's very important that we leave a residual stromal bed about 300 microns. If you do not respect these limits, the cornea will be unstable, leading to regression or ectasia. And it's very important for me to speak about regression, because everyone speaks of ectasia. Of course, ectasia is much more, we see here the ectasia is much more dramatic, much more serious than regression, but regression is a very important point of LASIK, mostly if you do high ametropia with LASIK. And regression, as we see in the top slide, can be defined as a progressive loss of effect without increase in axial length, so this is not progression of the myopia, and with no topographic abnormalities. And many papers we see for high myopia, for example, give us a follow-up of 6 months, 1 year, and regression tends to go farther. Why there is regression? There is a regression because of the corneal remodeling, because we cannot flatten. This is more important for myopia, also for hyperopia, but we cannot flatten the cornea as we like, and there is also epithelial hyperplasia that leads to regression. What I want to show you here, of course, is our inclusion criteria for LASIK. For us, we don't perform LASIK unless the cornea is more than 500 micra. Maybe now we are using thinner flaps with the femtosecond, we go to 480 micra. Never below that. In our experience, if we go below that, we can have problems. Of course, it's the stroma bed we also have seen, and it's very important that also the curvature of course also gives us the limits of LASIK. We cannot flatten too much the cornea or steepen too much the cornea. I show you some personal data, and this is a very old study we did maybe 15 years ago. And in this study, where we had a spherical equivalent about -8, so we're treating high myopia, we did a study comparing the regression of the surgery, of the myopia, dividing them in groups of pre-op corneal thickness. And we saw here, and at that time we did LASIK in thinner corneas than we do today, we saw that if the pre-op corneal thickness was lower than 470 microns, the regression was very important compared to the other groups. In the other groups, it was not so important if it was like this, to very thick corneas. So this was the cutoff at that time, and at that time it taught us, this study, that we should not do LASIK in corneas below 500 microns, 480 microns. So these are our personal data. The same for the flatness of the cornea. This has more relation with the contrast sensitivity, comparing the steepness or flatness of the cornea. That taught us also that we should not go up 47, 48 diopters in steepness or 34 diopters in flatness. Pupil size is not important. So of course, if the cornea is irregular, of course you cannot do LASIK, we know that. So I gave you two examples also, a good example and a bad one. This, of course, is the good example. It is a -7 case. You have a thick cornea, a steep cornea, and a small pupil. This will be a very good example to do a -7 ablation. That is, for us, a higher limit of ablation. And this, of course, is the bad case. Thin cornea, flat cornea, and large pupil. So, of course, as Francisco told us before, maybe a 2 diopter case can be more risky than a 5 diopter case, depending in the thickness of the cornea, in the K readings, the pupil size, and other important points. So, failure to follow the guidelines can lead to corneal ectasia, to regression, to loss of lines, on all problems that we have. So, in our experience, LASIK in thin cornea turns in unstable cornea and leads always or almost always to regression, maybe ectasia, but still regression. We can go contour these with a small optical zone, then we can get glare, halos, and low mesopic vision. And of course, the flattened or very steep cornea leads to also loss of lines of S-correct visual acuity and low contrast sensitivity. So, in thin cornea, what we do? If you have a low hemetropia, like myopia below -5, or hyperopia below +3, with a normal topography, we prefer to do surface ablation. We prefer surface ablation, we are on the safe side and do not do LASIK. On the other hand, if you have a high hemetropia, we do, or a low, or even a low hemetropia, if the topography is irregular, we prefer to do phakic or pseudo-phakic IOL according to the age of the patient. So these phakic and pseudo-phakic IOLs, if the inclusion criteria are respected and the surgery is okay, they give us accuracy, stability, and long-term follow-up without complications. So if we cannot do LASIK, we do this kind of intraocular surgery, and this is my choice for these situations. Thank you very much.
Thank you, Dr. Antonio, always precise and to the point. So to try to solve this or to summarize what we're saying or to try to have a good conclusion, Dr. Carlos Martin from Spain will talk about the limits of laser refractive procedures in thin cornea. Dr. Carlos.
I think my colleagues have spoken all about thin cornea, but I'll try to say something. I have to speak about the limit of laser procedure in thin cornea. Thin cornea in general is cornea less than 500 microns or cornea with more than 500 microns with higher ablation or with thick flap. Actually, we're speaking about the risk of ectasia if we reduce the stromal bed. LASIK is a refractive surgery of choice in Spain between 20 and 45 years old and people without presbyopia and patients that want to be operated with refractive surgery in our clinic We make a preoperative LASIK evaluation with refraction, psychroperiscopic refraction, aberrometry, Schirmer test, and tomography study to know if there are some kind of problems about topographic, keratometric, or pachymetric problems. Some years ago, the limit was about 250 microns, but now limits have changed, are changing now, and there isn't a magic number to say that the point that there are no problems with corneas. There are other factors join it, like topographic, keratometric, or corneal hysteresis, etc. But we know that more residual stromal thickness, less possibility of ectasia. These 5 points are the parameters to consider: the preoperative central corneal pachymetry, corneal flap, corneal ablation, residual stromal bed, and postoperative central corneal pachymetry. Maybe this graphic is the most reasonable relationship between residual stromal bed, corneal ablation, and corneal flap. We need to keep at least 60% of preoperative pachymetry, or 300 microns in stromal bed, higher of both. And the other numbers is easy to know. We can use about 20% of preoperative pachymetry in corneal ablation, and at the end we have to finish with more than 400 microns in the postoperative central corneal pachymetry. Current tendency now is increase residual stromal bed to decrease the risk of ectasia, always with high quality ablation and generous optical zones. And we are saving cornea thickness with optimized ablation profiles and thinner flaps or no flaps. LASIK means LASIK with microkeratom. We could use up to 470 microns of pachymetry, but I don't like too much LASIK under 500 microns. I only use LASIK in some cases with pachymetry near 500 microns and with shallow ablation. We use always 150 microns thickness flap to calculate the residual stromal bed, because there is a big variability with the microkeratom in the thickness of the flap. We can get flaps about 100 microns with femtosecond laser, with predictable flap thickness about 10 microns. The pachymetric graphic are the same that laser, and we need to keep about 60% of preoperative thickness or preoperative pachymetry, or 300 microns in a stromal bed. Then we save some cornea, and we can use in operate patients with higher ablation, or save and to be bigger stromal bed. Surface ablation is for me a main treatment option in thin cornea. PRK is about more than 10% of laser procedures in our hospital. And some of us use PRK in special cases like thin cornea, surface problems, keratometric or topographic problems, and risk activities like policeman, fireman. This other graphic, I think the same. I think this is the most reasonable relationship between stromal bed and corneal ablation. The law is the same. We need at least 60% of preoperative corneal pachymetry, or more than 300 micras in the stromal bed. We can use about 20% of the cornea in corneal ablation, and at the end we need more than 400 micras in the postoperative total pachymetry. There are other options like laser procedures with accelerated cross-linking. Cross-linking reduces risk of ectasia, same for that in keratoconus, and reduce to the possibility of regression, and can be used in high metropy treatment, retreatment, and keratoconus family history, for example. I think it's very interesting for laser procedures in thin cornea, but nowadays we use cross-linking only for therapeutic treatment of keratoconus yet. Facet lenses are used when laser procedures are contraindicated. I use ILC, and usually patients out of the range of the laser when laser procedures are contraindicated, when laser procedures are limited, and when patient has the best refractive surgery. Is for some surgeons the first choice. It's not for me, but it's obvious, but it's true. There are no possibility of corneal ectasia. We know that despite the respecting limits, corneal ectasia may occur. In my opinion, we shouldn't closer to limit of cornea thickness, and we have to save the maximum stromal bed. I like using pair key for thin corneas and limit cases of Lasik, and I use ELC for limit cases of any laser procedures. And nothing more. Thank you very much.
Thank you very much, Dr. Ka. So our next debate will be about laser refractive surgery and dry eye. Do you do laser refractive surgery in dry eye, yes or no? So we'll go first through the talks of the two speakers, and then we'll ask the question for the audience. So Dr. Sherif Emerah from Maghrabi Dubai will talk about selective laser in patients with dry eye. Dr. Sherif.
Good afternoon, everybody. My talk today will be focused on can we do LASIK in dry eye? This is a simplified tear model. We all know that the tear film is composed of 3 layers. By definition, according to 2007 update definition by the Dry Eye Workshop Committee, dry eye is multifocal disease of the tears and ocular surface that results in symptoms of discomfort, visual disturbance, and tear film instability with potential damage to the ocular surface that's accompanied by increased osmolarity of the tear film. Maintenance of the health of the tear film is achieved by constant feedback mechanism between the ocular surface, brainstem, and lacrimal gland. Photorefractive surgery comprises the sensory nerve supply of the cornea, so decrease the afferent input to the lacrimal function unit results in decreased tear secretions and decreased blink frequency. The impaired removal of inflammatory cytokines from the ocular surface and tear hyperosmolarity, causing inflammation and pro-inflammatory cytokines. This is in vivo confocal microscopy. This is the upper one before the LASIK and the lower one after the LASIK. You can find decreased in length, width, and tortuosity of subnasal nerve fibers. So dry eye is a common sequelae after photorefractive surgery, and the incidence of post-LASIK dry eye is ranged between 8.3 to 48% based on symptoms plus or minus clinical finding. So what we can do for this, for preoperative assessment, we have to take a very good history from any patient seek refractive surgery. You have to ask him if there is any history of contact lens intolerance, if he is using medication, because there is some medications affecting causing dry eye, like beta blockers, like topical antihistaminic, preservative topical eye drops. So he has to stop this or shift to unpreservative topical eye drops. Clinical examination, we have to see if there is any lid abnormality, conjunctival hyperemia, meibomian gland dysfunction, and also we have to see if there is superficial punctate keratitis on the cornea. We have to do the objective dry eye sign, which I do for all patients seeking refractive surgery. I have to do Shermer test, tear breakup time, and corneal fluorescein. There is some risk factors for patients for the risk of post-operative dry eye, high preoperative refraction, for high myopia, of course, because we ablate deep, and for high hypermetropia, because we are making the cornea more steep. This affects the ability of the eyelids to distribute the tear film on the cornea. Female, especially in the perimenopausal period, autoimmune disease like Sjogren, rheumatoid arthritis, contact lens intolerance. There is many grades for superficial punctate keratitis. These grades depend on the area and density. So if there is a pan-superficial punctate keratitis and staining of the conjunctiva, that's a red flag that the patient has a real dry eye pathology. There is a specific, more consistent and specific test for dry eye, the tear hyperosmolarity. If it's more than 308, this is a mild. More than 316, this is moderate to severe. So this is the grade for dry eye. It's mild, moderate, and severe with stress and constant. Usually in the grade 1, there is just we are concerned about the symptoms of the patient. Usually the tear up, the breakup time, and the Shermer test is normal. So in the grade 2 moderate, we start the tear breakup time start to decrease, and the Shermer test start to decrease. So prophylactic optimization of the ocular surface for a few weeks to 3 months before surgery helps to avoid post-operative dry eye. We have many lines of treatment. We have artificial tears, punctal occlusion, topical cyclosporin, lid hygiene, and topical autologous serum, nutritional supplementation. This is a normal ocular surface with a normal Shermer test. For mild dry eyes, I give usually unpreservative artificial tears for 6 times per day. Rarely we need to use the topical cyclosporin preoperative, and also we are rare to use punctal plugs before surgery. One of the preferred treatment for eyes with abnormal tear breakup time is the sodium hyaluronate, and because this stains the cornea between blinks and the shearing force causing them to liquefy. For moderate dry eyes, we use unpreserved tears applied more than 4 times per day. We usually start topical cyclosporin post-operative. We put usually punctal plugs at the time of surgery, and we can use short course of topical steroids. The punctal plugs, the effect on punctal plugs is about for 74 to 86% for the patient, and we have 2 types. We have permanent, the collagen one, and we have silicone absorbable, which can stay for up to 2 to 6 months. Can we play the video, please? This is what I do for the moderate dry. Usually I used a thin flap, 100 microns by the intralaser. After doing the flap, we correct the vision by excimer. And then I put the punctal plugs at the end of surgery. For severe dry eye, we need to use topical cyclosporin for a few months pre-operative, and then we can put punctal plugs. But the idea is to have to improve the quality of the tear film before putting the plugs. So we have to also to re-examine the patient to at least to be confirmed that the patient is improved. The advantage of topical cyclosporin, it inhibits T-cell mediated ocular inflammation, and this is good treatment for meibomian gland dysfunction, and also is beneficial in nerve regeneration. There is a randomized controlled trial on patients with pre-existing dry eye showed that the cyclosporine given 1 month before the operation and stopped for 48 hours before the surgery and then for 3 months can improve the great tear secretions for 1 to 6 months post-operative. So for these patients with severe dry eye, if it's never normal, never do surgery on them. There is another immunosuppressive tacrolimus, and we have also to treat the meibomian gland dysfunction. And some prefer omega-3 and omega-6 can improve also the tear film secretions. During the operation, there is no advantage or there is no difference between making a superior hinge or nasal hinge. This is suggested for the to do the nasal hinge is better than the superior hinge, suggested that the long posterior corneal nerves predominantly enter the cornea at 3 and 9 o'clock. And this is studied quoted on a schematic of corneal nerve architecture by Moller on 1997. However, in 2003, Moller later published a review that revised their previous findings. So there is no difference between superior and nasal hinge, but we can change the hinge width. If we make the hinge more large, this is definitely can improve the dry eye post-operative. This is a study of 181 patients showed the incidence of LASIK-assisted dry eye was statistically significant higher in the microkeratome group comparing to the femtosecond group. This is the explanation of this, the less damage to the corneal nerves with the femtosecond laser due to the thin flap and less damage to the limbal cells of goblet cells due by the femtosecond fixation ring. The study comparing between the LASIK and PRK, they found that the LASIK patient slightly higher self-report corneal foreign body sensation. This has happened only in the first month. And the cause of this for the PRK, because of the mitomycin C, we are putting to, in case of treatment more than -3 diopter for myopia, can affect the dryness after the operation. Of course, relaxed smile theoretically leaves the most of the corneal nerves because you are not doing a flap on this. So there is advantage for the smile technique in case of dry eye patient. So for post-operative, we have to continue the treatment, artificial tears and topical cyclosporine and plugs. So in conclusion, the dry eye associated with refractive surgery is usually transient, and most cases of dry eye resolved with appropriate management. So for me, dry eye is not contraindicated in laser refractive surgery except in severe dry eye, not improved by preoperative treatment, or dry eye associated with collagen vascular disease. Thank you for your attention.
Thank you, Dr. Sherif. On the other side, Dr. Hisham Hamdy will not do laser in patients with dry eye. So let's hear what Dr. Hisham Hamdy will tell us about this.
Good afternoon. Okay. Okay. We all know that when the patient came to our clinic, laser refractive surgery is an elective and cosmetic procedure. So we should enhance the patient lifestyle and well-being. So don't make the patient miserable, please. This is very important. This is a patient seeing 20/20 and is coming to get rid of his glasses or contact lens. So should we do laser refractive surgery or not on this patient when he comes to our clinic? So I'm going to answer this in the next slides. And also, we have a refractive surgery in 2014-15. We have more demanding patients, and we have more post-operative. May I have my slide, please? We have post-operative dry eye syndrome is very common. The visual quality should be good, so we have a good tear film function, and we should optimize the ocular surface. This is very critical. And we all know that dry eye syndrome is very common, especially with aging, with hormonal change, and it is influenced by other factors that we all know, especially in hot temperate area and sandy area like our region. And this is many factors that aggravate the dryness or the dry eye. So what happened in dry eye? The patient has discomfort. Again, my slide, please. Discomfort, environmental intolerance, contact lens intolerance, impaired wound healing, increased risk of infection or inflammation. One of the indications that the patient came to your clinic is because he has dry eye that interfere with the contact lens wear is one of the most common reasons for seeking LASIK. So about 40 or 75 of patients experience dry eye or tear deficiency before LASIK, with pre-existing dry eye syndrome is often made worse after LASIK surgery. So how LASIK cause or exacerbate dry eye? Post-LASIK dry eye is caused by ocular surface denervation produced when the flap is created. And in 2002, there is a very nice presentation that showed that the number of subbasal and superficial stromal nerves is decreased by 90% after LASIK surgery. So this is a huge number. This is what the LASIK will do for the converting a healthy ocular surface to unhealthy ocular surface. So when I started to do my presentation, I Googled. So I found about 272,000 results of dry eye after LASIK. And two of the top 5 results, the first one by Margaret MacDonald. With LASIK, roughly half of my patient has dry eye complication after surgery, and half of these, the symptoms were severe. And there is a video also of a patient suffering from severe eye pain after LASIK. So I searched in the literature, starting from 2002, we found that in Journal of Ophthalmology 2001, they concluded that, the authors concluded that conjunctival and corneal sensitivity significantly decreased and symptoms scores worsened at 1, 12, and even 16 months. Another study by Donenfeld in Ophthalmology 2003, he concluded that LASIK induced significant reduction up to 6 to 1 year due to decreased corneal sensation. And there is many studies about the corneal sensitivity after LASIK. It ranges from 6 months to 9 months to return to its normal. And dry eye has an important sequelae. It makes regression, refractive regression. So in 2004, they concluded that regression was seen in 27% of the patient with dry eye syndrome. Also in 2004, Journal of Refractive Surgery, they make a consultation for post-LASIK unhappy patient, and they found that 30% of this unhappy patient, they have dry eye syndrome. Again, in 2006, in American Journal of Ophthalmology, they found that dry eye syndrome is 50% in eyes at 1 week and decreased to 20%. And there is no angiolocation made no difference. Again, in 2007, dry eye symptoms over 6 months in 20%. And also another study in Journal of Refractive Surgery, 2007, they have dry eye signs similar in both the control group and post-LASIK group, but was more significant worse in the control group, which is significant. Again, another study in 2008 studied the post-LASIK unhappy patient. They found also about 30% of the patient have dry eye. And a very good presentation in ARVO 2009, they found that by 5 years, post-operative subbasal nerve density is 80% of the preoperative level before LASIK. The FDA Advisory Committee met in April 2008, and they concluded that a refractive surgeon should identify candidates with signs and symptoms of dry eye during the preoperative evaluation. These individuals are at greater risk for developing post-LASIK associated dry eye. Vigilant identification of this candidate allow appropriate counseling and pre-treatment, or in some cases, exclusion from LASIK surgery. And we should put in our mind that preoperative risk factors for post-LASIK dry eye depend on the degree of the myopia, depth of laser treatment, female, gender, dry eye, contact lens use, lid margin disease, eyelid anomalies, diabetes, systemic medication like the Racoten used in acne vulgaris, and when to avoid surgery to dry eye. When I examined the patient, other than the symptoms, if I found that the patient has vital conjunctival staining and corneal staining, not candidate until improved with the treatment. And also, when I'm doing my regular patient, I'm using small flaps with large hind to decrease the risk of postoperative dry eye, thin planar flaps, especially used with femtosecond laser, and bevel inside cut improve the corneal nerve apposition by Donenfeld in 2009. So my take-home message: don't laser in patient with dry eye syndrome. Treat the dry eye and see the patient again before surgery to see whether dry eye is controlled. If not, don't laser. If controlled, can laser with caution and appropriate preoperative discussion and informed consent, especially if you are facing a very demanding patient. Effective preoperative, operative, postoperative care of dry eye will decrease the incidence and severity of dry eye, increase quality of vision, increase the speed of visual recovery, decrease the incidence of enhancement. If this was your eye, would you think of LASIK? Thank you very much for your attention.
Thank you, Dr. Hisham. I think it's a very comprehensive lecture. So now we can use our voting pads and ask the question. In a patient with dry eye seeking laser refractive surgery, would you manage him by just laser refractive surgery or not? Do we have votes here? So most of the answers were treating dry eye first and then laser refractive surgery, equal to the number of no laser refractive surgery if the dry eye patient persists even with treatment. So we have to see any improvement before. Okay. Who's playing with the numbers over there? So no laser refractive surgery in patients. It's coming again to the same concept. So let's move on in our session. The next debate will be between Dr. Safwan and Dr. Alaa about customized laser refractive surgery. So if you are going to do laser refractive surgery, will you do topography guided laser ablation or wavefront guided laser ablation? So Dr. Safwan will talk about the topography guided laser ablation, which he thinks it's better. Dr. Safwan.
Good afternoon. I think that we need to shift to another debate subject that's also in the LASIK, but here in the profile of the laser. Topographic guided versus wavefront guided laser correction in myopic patients with the large pupil and high order abrasion. I don't have any financial disclosure with any product will be presented here. Topographic guided customized ablation, the hallmark of topography guided customized ablation is that it's designed to address corneal issue exclusively with an emphasis on smoothing or normalize the anterior corneal surface. It's often used to treat corneal abnormalities such as myopia and hyperopia with high-order abrasions, corneal scar, and keratoconus. But we have a different terminology, topographic guided and topographic guided customized ablation. And definitely there's a lot of confusion here. We need to just give the definition to topographic guided ablation and topographic guided customized ablation. The topographic guided ablation is the abrasion-free profile that use corneal map, topography, tomography, or both in one, to get K reading, central corneal astigmatism, pachymetric value, required for ablation laser, which in turn might have in certain machines ability to treat the induced spherical abrasion. This ablation profile cannot treat any existing corneal nor co-ocular high-order abrasion. And that's what we mention abrasion-free. Topographic customized guided ablation, this ablation profile uses corneal wavefront, corneal high-order abrasion that can be derived from corneal topography, elevation map, incorporated it into Zernike polynomially 7th order using topotomographic corneal map, getting the K reading, central corneal astigmatism, geometric center or pupillary center, and the pachymetry from the corneal map. The existing and the induced corneal high-order abrasion will be treated in this profile. Now, important points mentioned by our colleagues that the refraction here in both profile can be chosen by the surgeon. And I think that Dr. Hani mentioned a lot when he was treating the keratoconus by topography, guided ablation. That's otoref is derived from, that's refraction is derived from otoref, and the surgeon can apply it in this profile in reverse to wavefront guided. The surgeon cannot manipulate the refraction because refraction is coming from the machine. And in addition to that, the surgeon have the ability to choose corneal astigmatism and select its sign, putting the astigmatism in a plus to save tissue. Now I select two tangential topography for a highly abrated cornea, just to show the difference between the two. And you can see that same patient, just return the slide, please. Same patient with the same profile, with the same optical zone, but here abrasion-free, and here with customized TCAT. That's what we mention it. It's clearly that here it's not showing any treatment for high-order abrasions, while here it's treating the refraction and the high-order abrasions in myopic hyperopic pattern. This myopic hyperopic pattern reflecting the very high amount of coma. It's around 5.78 micrometer. Those two profiles definitely shows that the ability of TCAT to treat corneal high-order abrasions is much more than the abrasion-free. Next. Advances in TCAT, the ability to select the most clinically significant corneal wavefront manually all through the software, ability to incorporate algorithmically the selected high-order abrasions with the refractive error, aiming to save tissue and prevent overcorrection, customized ablation profile that's able to treat the induced spherical abrasion, trefoil, coma, the use of advanced tracking system, 7th D, the use of aspheric transepithelial PRK, 55 micron central and 65 micron peripheral. So why topographic guided? Topographic map can analyze up to 8.5 millimeter of corneal diameter. Topographic map is not limited to pupil size and measure much larger amount, around 6,000 points, which render much more accurate information on the corneal irregularity, and it's not affected by patient accommodation. Topographic map can be obtained almost in any case of corneal irregularity, even in high-abrated cornea. Corneal wavefronts can be derived from corneal topographic elevation map, as I mentioned, by incorporating it into Zernike polynomially. And as we know that more than 90% of wavefront irregularities are corneal irregularities. Topography gives us more accurate information about the periphery of the cornea, which is where most of the aberration lies, especially if we are using tangential, not sagittal. In sagittal map have a limitation to reach the periphery. And topography not affected by internal optical components such as early cataract. So why not ocular wavefront? Ocular wavefront sensors available today analyze up to only 1,452 points. Therefore, this type of customized ablation is less effective in patients with high level of corneal abrasions. Ocular wavefront analysis is restricted to pupil size, affected by patient's accommodation. Ocular wavefront treatment center the ablation on the pupil, while topography image is centered on the apex of the cornea. And as we know, the visual axis is closer to the apex of the cornea than the pupillary center. Wavefront is dynamic measurement. So there is no perfect wavefront. Of course, there is no perfect topography, but the standard deviation fluctuation in between them shows a much difference, much less in topography. If the problem is on the corneal surface as the result of the previous laser surgery or scar or keratoconus, wavefront is not going to add any magic ingredient. And if problem is in the lens, we do not want to treat at the cornea. If some of the lenticular abrasion become, and that's the debate that we can, when we are treating TCAT, there will be some lenticular abrasion that will be lifted. Those will be diminished greatly over time, since the crystalline lens is a dynamic structure and can adjust itself to compromise for corneal high-order abrasions to a certain degree. Now, one of the frequent cases that coming to our centers is that patients have been treated with a LASIK and suffered from night symptoms with high spherical abrasion. I think that was interested to present this case that came to me 3 weeks back. Myopic patient, 44 years, female, treated 5 years back with abrasion-free topography, guided LASIK. The optical zone used was 6.5 as a default in that machine. Monocular vision approach was used, right eye for knee, left for far. She presented to me with a night symptoms, starburst and halos. Scotopic pupillary diameter was 7.3 millimeter. She has high spherical abrasion, 1.19 micrometer, with refractive error of right eye minus 0.75 and on minus 0.5 diopter 120, and left plus 0.25 over 0.5 diopter 175. Her visual acuity was 0.9 unaided left, and she was very concerned about her visual acuity for distance, but she cannot drive. She has a night symptoms. What's the proper approach in our opinion? That what we need to use to treat her night symptoms without affecting the distance vision? I put 4 options. Topographic guided abrasion free with optical zone of 7.3, TCAT with optical zone of 7.3 millimeter with the use of refractive module that can incorporate the corneal high-order abrasion with the refractive error of the patient, ocular wavefront with optical zone of 6.5 with correction of all ocular high-order abrasions and the patient's refractive error, no treatment. When we are discussing the first, just return back to the first to the previous slide, please. The first option, topographic guided abrasion abrasion free with optical zone of 7.3, what we are expecting the residual refractive error. The patient will be shifted to the myop, because when we are enlarging the optical zone, we are just treating as a hyperop. So we might affect the distance vision. The third option, ocular wavefront with optical zone 6.5, because we cannot enlarge her optical zone. We need to treat high-order abrasions as they claim that we can treat ocular high-order abrasions in this patient, that she has a high refractive, high spherical abrasion. The expected result is we are pushing this patient to the hyperop overcorrection. That was the, next please. That was the primary page on the machine showing that I centered my treatment to the central geometrical center, and I used the same manifestation of the authoritative manifestation for the patient. If we will go back to the second slide, please. Optical zone here shows clearly that used 7.3, and I went to the manager of high order abrasion. If we will go to the manager of high order abrasion, we will see, next please, just this slide shows that her spherical abrasion was 1.19. Next please. That's the manager of high order abrasion. Have two modules, the pyramid module and the refraction module. In the pyramid module, if we will go to treat all these high order abrasions, we will do a non-specific TCAT, and that's present in other machine. Here we have the ability to select manually among them and by using the software. I use the software to give me the most significant high order abrasion, and that's what gives me. It treats only the spherical abrasion with few of them that the software considers that it's significant to be treated. The second issues, just please the previous one, the previous slide. Here, the amount of maximum ablation was 39. If we will go to the second slide, we will see that it's been reduced from, 42 micron to 39 micron after selection. If we will go to the second, please. Here I went to the refraction module and applied for her refraction. The refraction module has a constraint. That constraint that can be used by the surgeon just to modify. This module will read the amount of the high order regions that have been treated and the optical zone that's been selected by the patient, by the surgeon, sorry, and the refractive error of the patient, and the selection of the surgeons for the constraint. I select to be almost 0. Next. So I put a constraint of 0.25 in sphere and 0.25 in cylinder with a variance in the axis of 1. 5 steps being taken, and the result is that the machine suggests plus 0.37 and minus 0.25 on almost same axis. Next. The high order abrasion is being treated significantly to 0.52 post-op. And that was the post-op result. Preoperatively, as we said, that the refraction of the left eye was plus 0.25, minus 0.5, to plus 0.12, minus 0.25. The axis 175 to 5. Pachymeter was 493 to 478. Bed thickness measured by the anterior OCT shows from 393 to 378. The visual acuity from 0.9 to 1. Spherical abrasion from 1.19 to 0.5 micron. And she preserved her visual acuity for the distance. Thank you.
Thank you, Dr. Safwan. So Dr. Alaa thinks that OPA, wavefront, topography-guided ablation have the same results in myopic eyes with low high order aberration. So Dr. Alaa Al-Dinasoury, please.
Thank you, Tamer. I think, again, I don't know if it's fortunately or unfortunately, we don't have a debate. I think we're talking the same thing because Dr. Safwan presented the cases with high order aberrations. So if you have patients with abnormally high order aberrations, then you have to treat the pathology. Here I'm talking about patients with excellent optics, regular patients, like 95% of the patients we are seeing in the clinic and doing refractive surgery, patients who have excellent vision with correction, with their spectacles, whether whether they're going to benefit from adding any wavefront or corneal guided ablation. But before we start, let me tell you a story here. Do you have time for stories? In 1990, when we started doing laser surgery, started with the PRK like everybody else. Then in 1992, we started doing the what we call today LASIK. And the transition between myopic keratomileusis with the cryolathe to LASIK was very fast. During only 6 months, we were doing what we called at that time myopic keratomileusis, excimer myopic keratomileusis, excimer MKM. That was a technique introduced by Lucio Borato, where we cut 300 thickness disc, then we put it upside down, stromal side up, under the excimer laser, and we do the ablation. And then we put it back on the patient's eye, started with onlay sutures and then no sutures. And then we got excellent result. And then they came with the flap, maybe a few months later, we started doing the flap, which was the normal transition. Why to do 300 microns cut if we can do only 160 at that time and then ablate on the bed? And here is the important point. We realized when we shifted from the Borato technique to the LASIK that we were getting better results with the Borato technique, but we didn't know why. But the LASIK, of course, was better, easier, faster, so we went with the LASIK. Many years later, we understood why. Because when you do the ablation on the back of the disc, you put the disc on a flat surface, and then you ablate with your laser machine. But if you do the ablation on the bed, you are ablating on a curved surface, and that's what we understood later on after the work of Theo Seiler and Jack Holliday and Cynthia Roberts. And then we understood that what we're actually doing is not what we intend to do. The amount of peripheral ablation is much less. That's what is called the cosine effect because of many reasons, including the curvature of the cornea, the fluence of the laser, and the angle of incidence. But at the end result for us physicians is that we are ablating less at the periphery. So then we understood why we were getting better results when we were ablating on the back of the disc, because we were doing what we intend to do. The second story, if you allow me, we realized also in the early 90s that our best patients are those who have myopic correction, then they end in overcorrection, and then we correct their overcorrection with the hyperopic ablation. Patients become so happy. We didn't know why. Again, a few years later, we understood why, because we are adding ablation at the periphery with this hyperopic ablation. That's why the patients have a better vision, better quality of vision, because we are decreasing the spherical aberration. So this is the whole story. And then came in the late 90s, all this hype of the high order aberrations, wavefront guided, blah, blah, blah. And then we had 2010 by 2010 and 2015 by 2015. And the companies that invested millions of dollars in these things, and then we have to use it. So back to the question whether we really need wavefront guided ablation or topography guided ablation for our patients. So what we did here in this prospective study, so can I move it from here? No. Yeah. I'm consulting for NIDEC and Star Surgical. So it moves sometimes, yeah. Yeah. On the doing an extensive literature review, there are mixed results. There are all kinds of results, all what you want. And the problem is, again, the definition of the optimized, customized, wavefront guided, wavefront topography guided. There are lots of differences between different platforms. But the bottom line is you need to do what we call optimized ablation. By optimized ablation, I mean enhanced peripheral ablation, more ablation at the periphery to negate the effect of the loss of the efficiency of the laser at the periphery. That's all what you need to do. With the NIDEC platform, we have the OPD Scan 3, we have the OPA planning software, and we have the Quest Excimer laser working together. The OPD Scan 3, in brief, is a machine that gives you both topography and wavefront analysis at the same time, which is the strength of this machine. Also, it can objectively measure the quality of vision in many ways. The most important is the MTF graph that I use on a daily basis in my practice. The OPA software, OPA stands for Optimized Prolate Ablation. The OPA planning software is the surgical planning software. It gets the data from the OPD. It uses both topography and wavefront. It's not topography or wavefront, it's both together. To plan or to create a shot data that would compensate for the loss of efficiency or of effectivity of the laser at the periphery. And this was based on previous data with the same machine. With the OPA software, you can do three things. You can use either OPA, which means you are having enhanced peripheral ablation, correcting only the spherical aberrations. That's one. You can do what we call wavefront OPA, which is OPA plus wavefront guided ablation to correct the entire high order aberrations as seen in this table. And the topo OPA, which is OPA, which corrects takes care of the enhanced peripheral ablation, then correct the topography based on the wavefront derived from the topography. So it's topography-guided aberrations. So we were very interested to know if correcting the wavefront error or the entire eye wavefront error or the corneal wavefront error would add anything to our patients when we do the OPA only. In the previous study, we showed that OPA is better than conventional treatment. Of course, we all agree on this. So our aim was to compare LASIK with OPA in one eye and LASIK with wavefront OPA or topo OPA on the other eye. So we had prospective randomized study on consecutive patients, regular inclusion criteria for myopic patients. Each patient received OPA on one eye. The other eye was randomized to receive wavefront OPA or topography OPA. We used the NIDEC Quest, we used the Intralase, the IFS, the 5th generation. We looked at all possible outcome measures. Most important is the contrast sensitivity and the subjective questionnaire. We have 56 patients, 112 eyes at 6 months, with more than 80% follow-up rate. This is the preoperative demographics. There is no, you would expect no statistically difference because these are two eyes of the same patients. So the manifest refraction is similar, the aberrations are similar, and notice that the aberrations are all less than 0.3 microns, which we see in most of the normal populations. Looking at the uncorrected visual acuity 6 months after the surgery, there was no significant difference between the OPA eyes and the wavefront OPA, the contralateral eye. The same for topography, guided ablation as compared to optimized ablation. Looking at the gain or loss of corrected vision, again, there is no. Few patients gained one line or unchanged, but no patient lost 2 or more lines in any group. Very similar outcome. Looking at the predictability, you see the scattergram is very compact. The linear regression shows very high predictability, very similar in both groups. OPA versus topography, again, the same compact curve. Spherical aberrations was really interesting to see it, and conclusion is we still induce little bit of positive spherical aberrations, much less than the conventional treatment, but there is no additional value in using a wavefront or topography-guided OPA on the OPA alone. Looking at the high-order MTF, which is an objective and easier way to measure, the less time-consuming way to measure the contrast sensitivity of the patients. You see both curves are very almost identical, whether topography guided or wavefront guided or OPA. The HAX is one of the really very good instruments to use to measure the contrast sensitivity system. We used this a little bit late in the study, so we compared only post-operative outcomes, and again, we did not see any significant difference between OPA versus wavefront or OPA versus, now it doesn't move at all, OPA versus topography. So should I direct it any? Yeah. Okay. This is an example of topography, and these patients were around -4 diopters of myopia before the surgery, and you can see how nice the topography is. It's almost prolate cornea, very nice corneas after treating 4 diopters of myopia with any of the 3 techniques. When we asked the patient, which eye do you prefer, the majority of the patients had no preference. Well, both are the same. We're happy with both eyes. And some patients, equal number of patients, preferred OPA versus wavefront on one side or topography versus OPA on the other side. And the preference here, when we look back to those patients who preferred one eye, was not due to the quality of vision, but maybe due to a little bit of residual 0.25 or plus 0.25. So in conclusion, we strongly believe that it's all about optimizing the ablation, taking care of the loss of the effect at the periphery, rather than doing any wavefront guided or topography guided ablation. So they are similar in refractive outcome, similar in visual outcomes, similar in the quality of vision and the patient satisfaction, and the much better than the conventional treatment where we do not correct or compensate for the loss of the energy at the periphery. So there is no advantage for attempting to correcting the high order aberrations, whether entire eye high order aberrations or corneal high order aberrations in patients with normal optical system, with excellent optical system. But for those patients who had previous refractive surgery, this is, of course, a totally different story. And I thank you very much.
Thank you, Dr. Alaa. So I think that there is, actually, as Dr. Alaa said, there is no actually debate. It's only that sometimes we need to do topography-guided or wave-guided special cases, but in general, the conventional treatment will give us the same results at the end in most of the laser treatment. So we'll skip this question and the audience votes for this part, and then we'll go to the last one because we are running out of time. For cases of post-LASIK interface epithelial downgrowth affecting vision, and they are near to the visual axis. So what do you think should we do? We have again a debate between Dr. Safwan. It's not really a debate, but this is different methods of treating such a case. So Dr. Safwan Albeit will talk about his technique of removing this epithelial downgrowth by flap lifting only.
Good afternoon again. For post-LASIK epithelial ingrowth after affecting the vision and near and affecting the vision and near visual axis, removal by flap. That's my opinion, or that's my debate. Let us take a general information about the causative factor for the epithelial ingrowth. I think that there is a lot of issues that we can prevent before discussing the matter of treating. Poor adhesion of the flap to the stromal bed following excessive irrigation and or manipulation of the flap edge. That also we can prevent it. Poor flap alignment as observed in displaced flap with folds or stria that mostly occurred in patients sleeping on face down position. We need to ask the patient how he is sleeping. That's very important. I'll show the diagram that I'm giving to my patients prior to the surgery. Epithelial defect irregularities or tag at the flap edge, especially following enhancement procedure. Complicated flap like thin buttonhole, incomplete or decenter flap, uneven cut with poor suction, or intermittent blades, advancement, irregular cut with poor blade quality, free cups. Laser ablation of the stromal bed margin beyond the cut edge, as it's observed in hyperopic LASIK treatment. The risk factor, those including old age, recurrent corneal erosion, anterior basement membrane dystrophy, patients with blepharospasm, history of similar complication in fellow eye, and LASIK over previous radial keratectomy, face down sleeping position again. Now this slide shows that this diagram I'm giving to my patients, sorry. I'm showing to all my patients that how they are sleeping. And during the second two decades, we have a habit to sleep in this way, and that might displace the flap. And I asked almost all the patients that having persistent 3-time they lifting the flap to remove the epithelial endograft, how they are sleeping, and they are sleeping in this way. And after treatment, I force them to sleep in that way. So I mark, and I might change all the approach if the patient insists that he will sleep in this way. That the diagram shows the peripheral epithelial endograft. It's not affecting the vision, diagrammed clearly by OCT, and I'm doing OCT for all the patients, showing them what we have. This kind of peripheral, we can treat it easily by YAG laser epithelialysis. And that issues is that YAG laser epithelialysis will leave a trace of inflammatory reaction, and that inflammatory reaction will be on both face, on the bed and on the flap, and that it will take a long time to disappear. That's why I'm not preferring treating an endograft in the center of the cornea. Second, as this. Because if I will treat it with a YAG laser epithelialysis, it will leave a trace, and you can, sorry, no, just please. It will leave a trace, and you can see that even with it's healed, and that's the border margin of previous endothelial graft. And it heals in the center, but it's affecting vision a lot. So if I will treat it by epithelialysis, it will leave the same trace, and still patients complaining. Now, our surgical treatment, small peripheral area of peripheral endograft can be treated, as I said, by YAG laser epithelialysis, where large, more central endograft require flap lifting. The goal of this surgical treatment is to remove the epithelial endograft, mechanical, with or without chemical use, like 25% of alcohol, laser, 10 to 20 microns, BTK, or cross-linking. Restore smoothness to the stromal interface to improve the vision is our goal, and close the fistula to prevent future endograft, and that's what we need to educate the patient to prevent sleeping on the face and prevent any issues that keep this fistula open. This video, you can run it please, shows an epithelial endograft. This is the nasal side, so that start in the temporal and end up nasal, and here it's aggregate in the center. Shows that starting from removing the bed, it's easily to remove because the epithelial layer separating that flap from the bed. Sorry to be late, but it's a lovely movie. All of us scared from removing the bed and having the such large epithelial endograft. The aim here is to prevent folding of the flap as much as I can. So I did my best. Now you can see a large, and I used sponge to remove, and then I found that, well, I need sharp blade. Remove it all, and I'm keeping margin around the bed edge, away from the epithelium. And that's important also. That margin should be at least 0.5 to 1 millimeter away from the edge. Now it's clearly seen that, see how it's clear that that edge and that margin away, epithelial cells away from the margin. Now the flap back. Now here, after this step, in my opinion, that whether we will stop and remove and return back the flap and continue just irrigating the side, or we will use an alcohol 25% or cross-linking. Well, sometimes, I see that, especially in persistent, I'm using cross-linking with alcohol or without. That's depend, because cross-linking is more than enough. Partial cross-linking, 2.7 joule is more than enough. With 2.5, if we are using 18 milliwatt accelerated cross-link, I'm using 2.5 exposure with riboflavin for 2.5 minutes. It will give me a full sterilization. Next, please. That's post-op, and see clearly that's a pre with its OCT, and that's post-op. Nice, clear, and there is no interface. Thank you.
So, Dr. Safwan, thank you very much. He prefers to remove the flap and do it surgically, but after knowing the sleeping position of the patient. So, it's very important for you, yes. Okay. But it's very weird to ask the patient though. Anyway, Dr. Jorge Alio will talk about his preferred technique in removing the downgrowth, epithelial downgrowth affecting vision using YAG laser epitheliolysis. Dr. Jorge.
Thank you very much. And now I will show to you our strategy towards epithelial ingrowth, which is indeed less frequent today because with femtosecond we have square edges, and this happens only, let's say, in reoperations, but we see cases that are recurrent, so this is important to know how to do and which is our policy on this. First, this was a very important issue that we developed in this book that we published in 2007, Management of Complications of Refractive Surgery. So most what I am going to tell you is in this book that will have a second edition next year. We have this surgical alternatives, lifting and manual removal. You have just seen about this. Debridement with flap suturing, debridement plus alcohol, cocaine, and other toxic medications, and neodymium YAG laser treatment that we published for the first time in 2008, even that it was reported by Guillermo Avalos some years before without knowing us at all, and I have to acknowledge that he did this topic even before us. How we do the treatment, because obviously you have complications if you don't use it properly, and this is my advice. Adjust your laser spot to deliver the energy at the interface with the first spot as close as possible to the horizontal and vertical center of the patch of the epithelium being treated. And you have to target the minimum energy necessary to create a small bubble, the minimum energy necessary. Start with a pulse of 0.1, this is in our YAG laser millijoules, and gradually raise until cavitation bubbles appears. This is the level of cavitation, and you have to be careful. If you overpass this, you have inflammation and melting and scarring. Do not raise any further. Place 4 to 6 additional bubbles elsewhere in the same immediate area. They don't need to be one joined to the other. They should be apart. And bubbles are created along a patch of epithelium without connecting to each other. And then, very important, close the fistula with YAG laser spot at the flap edge during the first treatment. These are the different spots. Calculate the energy, as little bubbles as possible and close the fistula. With these rules, you are prone to have a successful outcome. The cells that are hit by the laser pulses are killed immediately. This is what we publish and is demonstrated by confocal microscopy. But then you have the acoustic shock that triggers apoptosis in the neighboring cells that reaches more than 1 millimeter. So 1 millimeter away from this area, you have apoptosis. And this apoptosis kills the cells without having any direct defect. That means that 2 or 3 weeks after epithelial cells disappear, even that you have not placed a spot over there. This is the way I do it. We reported 50 eyes for 37 patients. 80% were totally improved without any remain. 20% had mild corneal opacity and remained in the treated area. Most of them disappeared with time. 40% of cases required 2 or more sessions to eliminate epithelial ingrowth. 60% of the cases improved best-corrected visual acuity in 1 or more lines, and contact topography in parallel improved in quality, and we had no other complication. This is a video that summarizes what we do with corneal ingrowth. The consequences are severe because we have limitations in vision. Because of irregular astigmatism, these patients lost best-corrected visual acuity. They have flap melting if we have a thin flap, and definitely you develop flap and stroma scarring. So all these are the consequences of intraepithelial ingrowth, and this is why we need to treat with either of these alternatives that I have mentioned to you. We don't use any longer alcohol or cocaine because we haven't seen the effectivity of this so far, even that we used at the beginning. Look at this very dense epithelium. You have to think that we have 2 types of epithelial ingrowth, the proliferative and the non-proliferative. The proliferative are only epithelial cells. The proliferative is when you have goblet cells and then you have this type of mucin, this mucin itself, and mucin doesn't disappear with the laser. Only if the mucin is in a small amount, you can make it disappear, but should be very small. We use not an aggressive instrument. We use this discretion knife very carefully, and we scratch the surface of the, and then we use distilled water. Distilled water, by definition, kills the cells because creates an osmotic imbalance of the cells, and any one that has been left will disappear. Be careful, you should not hydrate completely the stroma because you can detach the endothelium. These hypertonic solutions could be harmful to epithelium. But if you are careful enough, you wash the surface with the distilled water. Distilled water is the one that you use for the extra time, is the one that is commercially available. And this hypertonic solution makes the cells to inflate and to explode and to disappear, or at least to detach enough from the fibronectin that is with the substance that attach the cells to the epithelium. And look here how the epithelium has been debrided as well. So the epithelium, we don't need to detach it, we need to leave it there, and then we use stitches. When we have a volume like this, we always stitch. You have about 50% of relapses, only what you have been seeing so far, but if you put the stitches, you really fix the flap, and we have 0 recurrences after lifting the flap, scratching and using hypertonic solution, and then suturing the flap. We use an RG marker. We place 7 stitches because the one in the hinge obviously is not needed, and we keep these stitches for about 10 days, no longer, and then we remove them. We use a contact lens, and this is the way in which we treat these severe cases when we have mucin in the interface. If we don't have mucin, we don't use any removal by any mechanical method. The treatment with neodymium YAG was the innovation that we published, and indeed is non-invasive. You don't need to touch the eye at all. And this is how, as I mentioned to you, the rules that you have to follow. Create the minimal bubble necessary with the minimum amount of laser, then to place isolated spots, to wait, because then in between the spots the cells will disappear, and then in about 2 to 3 weeks you have the effect. We usually not do a second treatment until 6 weeks after the initial treatment, because even later you have some chances that some of the cells disappear. And obviously you have to follow the minimal invasiveness in your procedure, as we do in all types of surgeries. This is the important concept. We have direct damage of the cells by hitting them with the YAG, and we have a distance damage which is created by the shock wave and the apoptosis that is created by the impact. And this is the way in which direct and indirectly you deal with these cells in a way that do make them to disappear. I think that this is the end of the, no, we have still more, but I think that can you run the video? Stop. Okay, what follows was some cases in which you could see the bubbles, how we did the impacts, and finally how with time they disappear. But it seems that the video is incomplete or cannot run any longer. So thank you very much for your kind attention.
Thank you, Dr. Ari. So I think we concluded this session for this day and for this first day of the Maghreb International Congress. So I want to thank you, everybody. Any questions for the audience before we leave for any of the speakers? Yes, please.
Its thickness, is it weak or it is tough enough to tolerate the procedure?
So I think that again, I agree with the concept of that thin cornea is not a weak and a thick cornea is not always a strong cornea.
Yeah.
The issue here, I think, is that still we don't have the actual precise instruments that measures actually the strength of the cornea, and even the machines that are available depending on the hysteresis of the cornea are not that accurate, especially in measuring the corneal thickness after many of the procedures, precisely the cross-linking procedures. So it will be still a debatable issue how to judge if this cornea is weak or thick, weak or strong enough to have a laser ablation or not, till we have an accurate instrument or machine that measures really the strength of the cornea. What do you think, Dr. Francesco?
My question was about the rule of aura. If there is any rule for
we
ocular
cannot
stress.
depend. I think
it is not, of course, it's a multifactorial actually, but I'm just, my question was how we can use the ocular hysteresis as one of the parameters to decide whether this cornea is strong or weak.
It's a question that has no answer today. I can tell you that in most of the cases, a relatively thin cornea is stronger than any LASIK-treated cornea, just to give you the comparison. So there is really no way for assessing by the measurement if a cornea is strong or weak enough if it has no other issues like keratoconus or so.
Dr. Alio has a comment as well.
Well, I think that this problem was partially solved by a paper that we published about 3 years ago. The first author is Brendan, second author is myself, with the largest series of corneal ectasia published, 120 cases, and the only one parameter that related to the development of ectasia was corneal volume. So corneal volume is related to the area ablated and the amount of cornea removed. You mentioned that, of course, but that was scientifically the first time that something has been verified. We didn't find, and this is your question, any relation with aura, even that we use in these cases, but it seems that aura is measuring a different type of corneal strength than what we are getting as an ultra-weak structure in the cornea following the removal of a large amount of tissue, but corneal volume is the answer. You have to calculate the corneal volume. If you go to the paper, you have all the data there. But aura was not related, even that I follow aura. I use aura, and if aura is abnormal, and abnormal is less than 10 to 9, okay? And if I have a thin cornea, I prefer to do PRK. In any case, thin corneas, I use PRK. Thank you.
Okay. So thank you, everybody, and see you tomorrow, inshallah. We have a very interesting session tomorrow in the morning on what are each doctor is doing differently this year. So see you tomorrow in the morning. Thank you.
Coming up in Hall A. Coming up in Hall B.